So yeah, I'm Jeff. I work at the Queen Elizabeth Hospital as a viral hepatitis nurse. We mostly do hepatitis C treatments. And also there's a nurse who I work with, Marjorie, and other people might know Debbie, who worked at the Queen Elizabeth Hospital for a while as well. Our office is based though in Port Adelaide, so we try and be sort of involved in community and primary health as much as possible. So we're sort of based in Port Adelaide in the Aboriginal Health Service there, and we also provide services and support for GPs and other support services in the community to get people onto hepatitis C treatment. So that's more or less our role, and I'll tell you a little bit about how you can access our service and other services like ours, because our service is sort of duplicated down at Flinders Medical Centre and the Royal Adelaide Hospital a little bit as well. So there are other nurses as well as the Lyell McEwan Hospital. So there's other places that you can access nursing support for hepatitis C and to get yourself or your clients or people that you know onto hepatitis C treatment. And as we know, the game's completely changed in the last month for hepatitis C treatment, which is fantastic. So prior to March this year, we were treating people with interferon-based therapies for their hepatitis C, which often meant, multiple side effects, 6 to 12 months treatment courses, and a lot of people who were probably denied treatments or couldn't access treatments because they had certain medical conditions or just weren't appropriate or didn't want to put themselves through that pain of treatment for 6 to 12 months and have to, potentially stop work, feel very tired, have numerous side effects. So now from March we've got new treatments which at the moment are we've got one called Harvoni and one which is a combination of two drugs, which that's Sivosavir and Decladisvir, and they're both for different genotypes of hepatitis C. But basically they're just tablets, and they're a treatment course of 12 to 24 weeks of tablets, and they offer you a much better chance of cure for the hepatitis C as well. So that's what's changed in hepatitis C, and that's why we're here today talking to you sort of about the new treatments and how you might access them. Because I think previously people might have had really good reasons not to be treated because treatments were so difficult, had so many side effects, and potentially quite serious side effects. Now treatments are so simple, accessible to most people. There's not so many reasons why people might decide not to be treated. There's a few potential groups of people who might not get treatment, but there's very few. So it's certainly something to have a discussion with your nurse or your health provider with, and think about potential ways to getting onto that treatment. And there are a few different ways to get onto it, but I'll talk about how we might be able to support you with that as well. So from March this year, we've put about 50 new patients onto the new treatments. And to give you an idea of what those numbers mean, last year I think our service treated about 62 people for the whole year, and we've managed to treat 50 people in 1 month with these new treatments. So really good news from that respect. And if we can keep going at that sort of trajectory, maybe we'll sort of get to a few hundred patients each year, which is sort of more what we're aiming for, and hopefully might be able to treat sort of 300 to 400 people in our service, which should go a long way to preventing sort of liver failure and liver cancers down the track for people in South Australia who are living with hepatitis C, because hopefully we'll be able to cure around about 90 to 95% of those people we put onto treatments. So the cure rate for treatment now is around about 95%. We sort of quote that number, but it's person to person, so it depends if you've got existing liver conditions, might be on some other treatments, that sort of thing. But mostly, from all the studies they've done with the new treatments, you're looking at about a 95% chance of a cure. Depends a little bit if you've had previous treatments as well, but we quote around about 95% chance. So that's really good news. And the new treatments are for people with genotype 1 hepatitis C and genotype 3. So that might not mean a lot to you, but certainly you can get a laboratory test for people with hepatitis C that will tell you what type of hepatitis C you've got. And there's 6 different genotypes. In regards to the genotypes, they don't really mean a lot in terms of the progression of the disease. They can mean a little bit, but not a lot. They're more for us health providers, because different treatments work for different genotypes. So it's really important that we know what type of genotype you have, and that's a test that your GP could do for you. And you can ask them for that test, or you can speak to a hepatitis nurse or someone else, hepatitis SA, who might be able to tell you sort of how to get access to those tests. It's important to know what genotype you have, because it really depends on which drug we give you. So for genotype 3, there's this Sivosavir and Decladisvir drug, and again, that's around about a 95% chance of curing the virus, and it's about a 12-week treatment course. If you already have cirrhosis of the liver though, it might be more like 24 weeks of treatment. For the genotype 1 we've got a combination drug called Harvoni, and that drug will give you, again, a 95% chance of a cure, and it's a 12-week treatment course as well, except for people who might have had treatment previously and have cirrhosis of the liver. So they might need 24 weeks. But most people between 12 and 24 weeks, and the majority of people need 12 weeks. In some cases that can even be shortened down to 8 weeks, depending on other factors like how much virus you've got in your system and things like that. But generally most doctors these days are using 12 weeks because they're just a bit conservative. They don't want to treat people for 8 weeks and perhaps not get the result and feel like they might have got a different result if they'd tried for 12 weeks. So 12 weeks is really short when you compare it to previous treatment durations, which we were looking at 6 to 12 months of treatment. So 12 weeks is really nothing, but we do ask for a few lifestyle changes during that period of time sometimes. We still don't know very well the effect of alcohol on treatments because we haven't really tried treating people in those who are drinking alcohol or drinking large amounts of alcohol, because the previous drug trials obviously have selected the best patients that they could find and tried to minimise any of those other risk factors that might potentially impact on treatment. So we don't really know if drinking is going to affect treatment outcomes, so we're trying to advise our patients to drink or not to drink while they're on treatment, alcohol that is, or to at least minimise any drinking that they do on treatment. And it might come to light over the next months to years what sort of effect alcohol does have on treatment. But other things that used to affect treatment outcomes were things like obesity, diabetes, things like that, fatty liver disease. We know that they're not affecting treatment outcomes very much at all. So hopefully things like alcohol won't. People can inject drugs while they're having treatment now. Again, we counsel people around harm minimisation and the risks of injecting drugs, but it's not something that's going to preclude people from having treatment for hepatitis C. And in fact, there's a real benefit in curing someone who's currently injecting in minimising any sort of transmission risk they might be for other people that they'd be sharing and using with. So that's a group of people that we're really keen to get in contact with and to try and offer treatment for if we can. It's a little bit doctor specific in terms of how each doctor will treat and what information they're going to give to the patients. But for us nurses, we try and treat as many people as we can as long as they're interested and engaged in treatment. The big factors for us is they're capable of taking a tablet each day, because missing tablets or missing doses of the drugs is one of the biggest risks for not having a good outcome with your treatment. It's one of those drugs you have to have a constant level in your system, and if that level drops off, you're at risk of developing some resistance against the drug and then failing treatment. So it's really important to try to have that tablet every day. So that's one of the factors we consider, that we've got people who can do that, but most people can do it. Some of the treatments require you to have 2 tablets. There are different drugs coming in the future that might require you to have different doses as well. As far as people who don't have genotypes 1 or 3, which are the ones that we've got the new treatments for now, there are certainly new treatments for them which offer them a better chance of clearance, but they might involve some of the old drugs, some interferon, some ribavirin. So we're not quite to the same point as we are for the genotypes 1s and 3s. However, genotype 1 and 3 make up about 85% of all of our patients. So they're the most important ones for us, or certainly we can get a lot of people onto treatment for those particular types. We're hoping that maybe in 6 to 12 months we'll have a different treatment option for the other genotypes too. So for genotype 4 and for genotype 6, which is the other two that we see relatively often, well, a small amount in our clinics, we might have some purely oral doses of treatment for those in 6 to 12 months, hopefully. So we're putting a lot of those patients off, hopefully, and waiting for some new treatments. Other things we like to know before you start treatment is what condition your liver is in. So that requires a few blood tests and things like that. And maybe a FibroScan test, which you might have heard of. It's like a small ultrasound where you just put a wave through your liver, non-invasive test, not a painful test or anything like that. And we can just do them inside the clinics. And that tells us if there's any scarring in your liver, because sometimes that could be important for treatment and might affect the time or the time frame around your treatment a little bit, particularly if you've had previous treatment. And it's good information to know in terms of follow-up as well, because people who've got severe scarring in their liver or cirrhosis of the liver will need to have continued follow-up for the rest of their lifetime to make sure they're not getting any liver cancer and their liver condition isn't worsening. So those people need to be in constant care. Whereas someone who's got hepatitis C and has very minimal scarring in the liver or no damage of the liver can sort of be discharged after treatment and cure, and we can expect that they won't have any complications from that, and have an improved, their liver will improve after we stop treatment as well. So that's something good.
Have to have the fibre scan before you go?
You don't have to. That's purely your doctor's decision. We like to do it because we like to exclude that someone's got severe scarring in their liver. But there are other ways to tell that. Perhaps not as well as a fibre scan, but certainly for someone who's only had the virus for a short period of time, let's say less than 10 years, less than 5 years, and doesn't drink a lot of alcohol and has otherwise a healthy lifestyle, are very unlikely to have severe scarring in their liver from hepatitis C. So they may not need a fibre scan.
And the fibre scans are only available at the big public hospitals?
They are only available. No, we do. Yeah, no, correct. They're only at big hospitals, but we do them privately for other doctors. So, for example, some doctors will ring us up and say, "I've got a patient here who needs a fibre scan. Can I send them to you?" And they just come into our clinic on one of the days that we're doing them, and we'll get them in.
Get the waiting list.
Yeah, there's not really, in our service anyway, they all work a little bit differently. So in our service at the Queen Elizabeth Hospital, we really just do them inside the clinics. So when someone comes for an appointment to see the specialist, we like to do a fibre scan on the same day.
Okay, that's great.
And we'll fit other people in who might need it on the same day as well. So we don't really have waiting lists so much. But other services do. I know in Flinders or Royal Adelaide you might have to book in for an appointment or something like that. But certainly private doctors can access fibre scans. They're certainly available to them. So it's a good point. But yeah, and you don't necessarily always need one. We can tell from other ways if there's other scarring in the liver as well. So it shouldn't preclude people from treatment. Other things you might hear of is that GPs can prescribe treatment now, and that's very true. But they do need the support of a specialist, so that's an infectious disease doctor or a hepatologist. So that means they need to either have a phone call or some sort of consultation with a specialist in order to start their patient on hepatitis C treatment. And if they do that, then it is possible for GPs to start patients. However, we haven't had much buy-in from GPs yet, or perhaps from specialists. So most people who are accessing treatment now are still coming through the hospital services. So the best way to do that, if you do want to get onto treatment, is get a referral from your GP to one of your hospitals, so a hepatologist or an infectious disease doctor. But I'd like to sort of spruik our service a little bit, which is the hepatitis C nurses, because what we do is if you get a referral to us, and you can just ring us on the phone, you can get your GP to send us a referral, you could get another service you're with, say it could be a social service, or someone can ring us and refer a patient. It can be many different ways that you can get into our service. And what we'll do is speak to you on the phone a bit about your own condition and sort of what's going on for you, and work out what you need in terms of getting you ready for treatment before you even see the specialist. That's one of our big roles. So what we try and do is, if you've got hepatitis C and we get a phone call saying, we'll get a referral, we'll ring you up and we'll say, what blood tests have you have done? We'll try and look them up in the system if we can, if you had this test, if you had that test. And if you haven't done it, we'll help you get those tests done before you get to hospital. And hopefully then when you arrive at hospital, you've got all these tests that have been done, and it's much easier for you to start treatment almost immediately than when you arrive at hospital. And most people now, we can usually get away with just one or two visits to hospital before starting treatment. And certainly there are new treatments now, so the doctors are a little bit cautious with them, but I think over time, as they get more comfortable with the treatments, there'll be even less and less visits for people who are on those treatments as well. But most people who come now might have one visit to start their treatment. So they'll come, and if they've had all the correct tests done, they'll hopefully be able to start on that day. Certainly today down at the Queen Elizabeth Hospital, I started 2 patients who would work with their GP to get all their tests done, make sure they had an ultrasound done. We did a fibre scan when they rocked up today, and they started treatment today, or they're going to have their first tablet tomorrow. So that sort of scenario is quite possible, and that's what we try and achieve if we can. If you just come straight to your specialist and you haven't had those tests done, that's still okay. We can do all of them inside the clinic. It might just mean that you have to come back in 1 month or 2 months after those tests have been done, and then start then, because usually they'll like to see all the results of those tests first. So by coming through the nursing service, which you can just find on the SA Health website, or through Hepatitis SA, we'll give you sort of our numbers as well. You can certainly access us, who'll tell you what you need to do before your appointment in order to get on treatment. And if your GP is really keen, then we can sort of speak to them and also advocate for them, potentially to talk to one of our specialists as well. Like I've said, it's not happening a lot now, but we'd like to see it happening down the track because it'll make it much easier for people to access treatments. And it'll also free up a lot of our outpatients appointments inside major hospitals, which means there'll be more space available for people who've got, really complex conditions or maybe chronic liver conditions and liver problems to see the specialist as well. So we're keen for that in the future. At the moment it's not quite happening, but I think it will down the track. I've only got a few more minutes probably to talk, but is there any questions about treatment and stuff?
I've got a couple of questions. One is, you mentioned that you were accepting referrals externally for FibroScans. Are those referrals coming from GPs or are they private specialists you're doing it for?
Mostly private specialists. We will do them for GPs though. If a GP wanted to send us a patient and they were, for example,
was interested in prescribing themselves.
Yeah, I can't see why we wouldn't do that. If the GP spoke to us or the patient even spoke to us, we could speak to the GP, and I can't see what would stop that from happening. And certainly if they know a specialist that's supporting them to get on treatment, they just need a FibroScan, we're happy to do it. Any way we can support patients to get onto treatment, really, we'll try and do that if we can.
Excellent. And my second question was, are there particular drugs that people are injecting that you are more concerned about while they're on treatment with drug-drug interactions?
Well, we're not that familiar with it yet, unfortunately. I haven't had a lot of patients who've been injecting frequently while they're on treatment. Some might have randomly sort of injected. And I haven't heard of any major interactions that I'm aware of. And I've checked out a few. Sort of for amphetamines and things, that doesn't seem to be a big problem from what I've read or what I've seen.
I know there are some more DAOs coming that have been trialled in people
in those populations. Yeah, okay. Well, I haven't read any of that information, so I'm not 100% sure. So it's a bit unknown, I think. But no one's particularly concerned about anything. There's nothing that's been red flagged, that's for sure. Certainly things like methadone and Suboxone and other sort of narcotics or things like that seem to be okay with treatment as well. So we haven't had any major problems with that. More of the interactions, because that's a good point that Deborah raises, is there can be interactions with these new drugs and other tablets that people might be taking. So they might be illicit drugs, but it also might be just routine medications. And what we're finding more is it's more than just the routine medications that we're having trouble with rather than illicit drugs. And some of those routine medications might be for gastric sort of reflux. Some of those medications can cause problems. Some cardiac drugs can cause problems. So there's a few different types that can cause problems. No, I haven't had any trouble with Valium. And I have had quite a few people on Valium and stuff. And so far, well, the ones that I've looked up haven't had any interactions. So. Yeah, most and a lot of the mental health drugs as well haven't had any major problems with either. It's sort of a case by case, so I can only tell you the ones that have come through my clinic and I've checked because there is a website we go to and we check for interactions. But not finding a lot of interactions. It's just important for us to check that for you because what it can do, these interactions can certainly make the dose of the drug that you're taking increase in your system, which can cause more side effects for you, or it could actually reduce the amount of the hepatitis C drug in your system, which could then mean you're underdosing yourself and potentially at risk of developing some resistance to treatment or having a bad treatment outcome for your hepatitis C. That's why we like to check all of them. And usually it's not a big problem because we can adjust medications with the specialists anyway if they are on anything that might be causing some interactions. And we do that sometimes for drugs that lower cholesterol. There's one particular one that can cause some interactions with the treatment and we might just need to adjust the dose for that or stop that for a period of time. But we do that in consultation with the other specialists and things. That's a good point.
And so in terms of to use the word I've heard bandied around, revolution, I keep thinking of that Beatles song. Anyway, so if someone's diagnosed sort of recently as opposed to someone that's maybe been living with hepatitis for 20 or 30 years, is it accurate to go out into the community and tell people that both people have as good a chance of clearing hepatitis C?
It's pretty close, I think. Certainly people who have already got existing cirrhosis of the liver might have a slightly decreased chance. But it's only it's only a little bit less chance. There are people who already have liver failure or really big problems with their liver, and sometimes that precludes them from having treatment because they're already at a point where their liver's under so much stress that it unfortunately can't deal with treatment. So there are that group of people who've already got past the point of cirrhosis and they're already sort of what we call it decompensating their liver is, which means it's really not doing its job properly. Those people we can't unfortunately treat with the new drugs at the moment, except if they're in one of the really high-tech treatment centres. So maybe Flinders Hospital trial treating people who have that level of liver problem. But in our centre, which is sort of where we concentrate more on the less complicated liver patients, then we wouldn't be treating that sort of patient. So those ones, which is a small portion, people with cirrhosis might have a cirrhosis, which is scarring of the liver already, severe scarring of the liver, might have a slightly less chance, but it's not much. It's certainly not what it used to be, that's for sure. It's definitely a huge change in terms of that.
And have you many people that are co-infected with HIV and Hep C in terms of drug interactions?
Actually, that's pretty good for that. We've got a couple who are HIV, hepatitis C co-infected on treatments now. And I know I'm not certainly the Harvoni, which we've been treating with it because they're genotype 1s, has been fine. We haven't had any interactions. It does depend on which HIV drugs they're on though. Some of them, which they might introduce to the regime, might have interactions. So it's a bit case by case for that. But certainly it's possible. It might take a bit of fiddling around. And certainly the infectious disease specialist is really important in terms of starting treatment for people who are co-infected because of those potential drug interactions.
So all that would be worked out before someone considered?
Absolutely. Yeah, we'd have to go through their drugs and see what they're on and perhaps adjust some things. But it's still possible. Yeah.
When you were talking about the different strains of hepatitis, which are the most that you see more common? You were saying about the but they've got number 2 strain.
Yeah.
It's not
Yep. We certainly see mostly the 3s and the 1s, which are the ones we've got the new ones for. 85%, I reckon. We see some 2s, some 4s, and a few more 6s. So 6 tends to be sort of more from the Asian region. So we see a bit of it around our area, around the Queen Elizabeth Hospital, because it was more common in that particular area. Whereas genotype 4 was perhaps more common in North Africa and Middle East, and so we see a few of them, but not heaps. Genotype 2 is still a nice, easy one to treat, but unfortunately it doesn't involve interferon, but it does involve a drug called ribavirin, which was in the old treatment regimes and can have some side effects as well. So we're hoping for the 4, 5s and 6s that there's some really good new treatments in 6 to 12 months' time.